Good morning, everybody. My name is Rena Pollack. You have my email up there in case you have any questions after the lecture. Please feel free to contact me. So the topic of today's morning lecture is a discussion about endocrine neoplasia. And what's great about this topic is that it's going to pretty much synthesize everything that you've been learning over the course of the last few weeks in discussing just tumors of the endocrine system. So what's great to me and what I like about endocrine is that we don't only deal with one organ system, and we really deal with multiple organs from head to toe. This may be somewhat daunting for a lot of you, that it's just kind of all over the place, but when you really think about it, it's a very organized approach, and it's really a lot of fun. So what I'm going to first do is I'm going to go through the different endocrine organ systems and discuss the different endocrine tumors that can exist basically from head to toe. So we're going to start up at the pituitary gland, which you guys heard about way early on in the course, where you can get neoplasms or pituitary adenomas in the pituitary gland. And essentially, all of the pituitary cells can become neoplastic and secrete excess hormones. So you can have prolactinomas with excess prolactin secretion, where patients tend to present with galactorrhea, visual field abnormalities, which we'll discuss a little bit more about this in this lecture, because not only can they occur sporadically, but they are associated with the familial syndrome MEN1. There also is development of non-functional adenomas, which tend to be detected incidentally in the setting of somebody possibly undergoing a motor vehicle accident, and they come in, they get imaging of the brain, and they find a pituitary adenoma there, which is not necessarily making any hormone, but is there and non-functioning. We can also develop growth hormone-producing adenomas, which you heard about, which tend to cause acromegaly in adults, ACTH-producing adenomas, which tend to cause Cushing's disease, and rarely we can also get TSH, FSH, LH-producing tumors. Moving down to the next gland, the thyroid gland, which you guys learned a lot about, you can get tumors occurring in the follicular cells, not only carcinomas, which I list here, but more commonly just adenomas, and also develop papillary or follicular carcinoma, which we discussed in the thyroid lectures, and then medullary thyroid cancer, which we'll learn about today, which occurs in the other cells, the parafollicular or C cells in the thyroid, and that tends to be associated also with a number of familial syndromes, which we'll learn about today, familial medullary thyroid carcinoma and MEN2A and 2B. And you can also develop anaplastic thyroid cancer, which is a very rapidly growing dedifferentiated thyroid cancer, which has a very poor prognosis. And then we can't forget about our parathyroids, which sit behind posterior to the thyroid gland, which we spoke about a lot yesterday in the small groups, where you can develop parathyroid adenomas or very rarely carcinomas, which tend to be very aggressive. Patients tend to have very high calcium, very high PTH. They tend to be malignant and can metastasize very easily. They're difficult to treat. And then parathyroid hyperplasia, which we touched upon yesterday in the small groups, where you learned a little bit about the MEN syndromes, but parathyroid hyperplasia of the glands is commonly seen in MEN1 and in MEN2A. Moving down to the pancreas and the duodenum, there's an entity called pancreatic neuroendocrine tumors, which can occur sporadically or be associated with MEN1, and we're going to learn about these today. The most common tumor associated with MEN1 is a gastrinoma, which tends to be found most commonly in the duodenum, but also in the pancreas, and insulinomas, which is the most common sporadic neuroendocrine tumor, but can also be seen in MEN1, and then more rarely vipomas, glucagonomas, somatostenomas, and non-functioning tumors. And then we have our adrenal glands, which you probably had a number of lectures on already, which you can get adenomas occurring in the adrenal cortex, which are called adrenal cortical adenomas, and they can produce any one of the three hormones that are produced by the adrenal cortex. That you can have aldosterone producing, known as Conn syndrome, which you heard about yesterday in the endocrine hypertension lecture, where you can develop primary hyperaldosteronism with elevated aldosterone levels, low renin levels. You can develop glucocorticoid-producing tumors, which is known as Cushing's syndrome, or androgen-producing tumors. And you can also develop adrenocortical carcinomas, which can be functioning or non-functioning, meaning making hormones or not. Those tend to be found once they're usually larger and tend to be quite aggressive. And then there are tumors that occur in the adrenal medulla, which we're going to talk about today, called pheochromocytomas, which can occur sporadically but also associated with familial syndromes. And I put here MEN2A and 2B because that's what we're going to be talking about today, but there are also a whole slew of other familial syndromes that are associated with pheochromocytoma, such as von Hippel-Lindau or neurofibromatosis. And we can't forget our male and female organs, the testes and the ovaries, which can also secrete excess testosterone and estrogen. So neuroendocrine tumors basically include endocrine and neuronal cells, and they're defined by their production of their cell-specific hormonal products, meaning the cell that is neoplastic is going to secrete the hormone that's associated with that cell, as well as general neuroendocrine markers. So those hormones, the peptide hormones, they have defective sorting and trafficking. So you tend to see an increase in the prohormone, meaning the precursor hormone, relative to the mature bioactive hormone. And what I mean by that is, an example I gave here is the proinsulin molecule tends to be cleaved, and you get the insulin, which is the mature hormone, and C-peptide, which normally you tend to see in normal individuals, elevated insulin levels relative to proinsulin. But in neuroendocrine tumors, the proinsulin to insulin ratio is elevated. Additionally, they can secrete granule-associated markers, which are not necessarily specific to the tumor itself, but they are found in neuroendocrine tumors in general, and those are most commonly the chromogranins, most commonly A, B, C, neuron-specific enolase, and alpha subunit. So here I have a table of different neuroendocrine tumors, just to give you an idea of how all of them can have elevated elevation of these granule markers, and specifically pheochromocytoma and carcinoid and gastrinomas, they have 80 to 100% elevation in chromogranin A. And why this is useful is because, let's say you diagnose one of these tumors in an individual and then they go for surgery to have it resected. Post-operatively, you can follow the chromogranin A and see that it trends down and continue to follow it as a marker of recurrence down the line. And similarly with the neuron-specific enolase and the alpha subunit. So the rest of the talk is really going to focus on the multiple endocrine neoplasia syndromes. We're going to go through the pathophysiology, the clinical presentation, the diagnosis, management, and screening of patients for MEN. And we're going to go through the three different kinds of MEN, MEN1, MEN2A, and 2B. So the multiple endocrine neoplasia is a group of heritable syndromes, meaning they're genetic. They can cause benign or malignant tumors, and they can be functional or non-functional. It's really hard to kind of remember which ones go with which tumors. Some useful mnemonics I kind of highlighted here, that MEN1 is associated with the 3 Ps, hyperparathyroidism, pituitary adenoma, and pancreatic tumors. MEN2A and 2B have 2 common features where they both have medullary thyroid cancer and they both present with pheochromocytoma, whereas MEN2A has hyperparathyroidism as its 3rd most common feature, and MEN2B is associated with mucosal neuromas, ganglionomas, and marfanoid habitus. So some mnemonics that people like to use is MEN1 is 3 Ps, MEN2A is 2 Ps, and MEN2B is 1 P, but however way you remember it is fine. So MEN1 clinically is defined as 2 out of 3 of the primary MEN1 tumor types, meaning either parathyroid adenoma, pituitary adenoma, or a pancreatic neuroendocrine tumor, or one of the MEN1 associated tumors plus 1 first-degree relative with MEN1. The prevalence is 1 in 30,000, which may seem not that frequent to you, but we tend to see this in clinical practice, especially here at Einstein. The genetics is it's autosomal dominant. Its penetrance is 95% penetrant by the age of 45. 10% of the MEN1 mutations arrive de novo, meaning they're not genetically passed down, and those are termed sporadic MEN1. So in terms of the pathogenesis, in 1988, the MEN1 gene was mapped to the long arm of chromosome 11, and then the gene was cloned in 1997. It's a tumor suppressor gene, which I'll get into the specifics of what that means in a minute. It has 10 exons and encodes the amino acid protein called menin. Menin has a role where it interacts with many proteins. It's involved in transcriptional regulation, genomic stability, cell division, cell cycle control, none of which of these actions really correlate with the phenotype that you see. So MEN1 really has no genotype and phenotype correlation. There have been more than 1,300 mutations reported to date, whereas 78 to 93% of MEN1 families have had documented mutations in the MEN1 gene. So what does this mean? So or how does this happen? So basically what happens is the patient inherits in their germline cells the first hit or the first mutation in the MEN1 gene. And the second allele is okay. But since this is a tumor suppressor gene, it requires a second hit, meaning a second mutation in the second allele to cause the clonal expansion. So that second hit occurs in the somatic cells, meaning your parathyroid cells, the pancreatic cells, or your pituitary cells, to develop the tumor and clonal expansion. In sporadic cases, you don't inherit any hits, so to speak, from the parents, so it requires two sporadic hits in the somatic cells, and that's why it's pretty rare to see sporadic MEN1. So in terms of the clinical features, I mentioned that there are three main tumors that we see, most commonly parathyroid, which occur 99% of the time, pituitary tumors, and pancreatic endocrine tumors. But I want you to be aware that there are other tumors that can present in the setting of MEN1, though they are more rare. You can get lesions in the skin, what's called collagenomas or angiofibromas. There can be adrenal tumors, which can be non-functioning or functioning, bronchial lung carcinoid, thyroid carcinoid, thyroid tumors. Although these are rare, they do exist, and you should just be aware that they are there. So this slide I put to point out the age of which the tumors are expressed in MEN1. And what I want to point out is that the first tumor that we tend to see in MEN1 is the parathyroid. That tends to present early on by age 30 usually. But commonly what happens is a patient will end up presenting for some other reason, like amenorrhea or galactorrhea. They'll be found to have a prolactinoma, and then somebody will somehow look back in their medical record and see that they were hypercalcemic all along. It just wasn't that severe or causing symptoms and went undiagnosed. So even though sometimes other features of MEN1 may be diagnosed first, usually the parathyroid hyperplasia precedes the other tumor presentations. So the clinical features of MEN1. So we spoke about this a lot yesterday in the small groups about hyperparathyroidism, and this preceded the lecture on MEN1, although that was in one of the cases there. Patients tend to present with primary hyperparathyroidism. It tends to be a 4-gland hyperplasia. You can also have hyperplasia of supernumerary glands. What I mean is a patient can be found to have an extra parathyroid gland that is found along the migration pattern of the parathyroid in the thymus or submandibularly. Tends to be detected when a patient goes for surgery and they take out the 4 glands and the hypercalcemia doesn't resolve. It's rare, but it can occur, and it can be seen with MEN1. The penetrance is 95 to 100% by age 50. And the mean age of presentation, meaning those that were not detected genetically, is between the age of 29 and 34. meaning people who you already have a suspicion or have been tested genetically for MEN1 are screened much earlier, and the mean age of presentation may be younger, or the hyperparathyroidism is detected earlier. But in patients who you don't have a pre-existing genetic diagnosis, it tends to present around 29 to 34 years of age. And the mean age of diagnosis of MEN1 in these patients tends to be a decade later, which is important because when you see somebody who has four-gland hyperplasia and is young, you should suspect MEN1 right off the bat. So the signs and symptoms you guys know pretty well. Symptoms of hypercalcemia, so they have kidney stones, arthritis, bone pain, constipation, peptic ulcers. They can have memory loss, depression. And the diagnosis is usually made by an elevated calcium level in the setting of an elevated PTH level. They have normal vitamin D levels and low to low normal phosphorus. The treatment of it, since it is hyperplasia of all four glands, removing one is not going to really help you. So you need to resect basically either 3.5 glands and leave half of a gland intact because we don't want to make them hypoparathyroid, or resect all four glands, and what we can do is transplant one of those glands into the non-dominant forearm, and that actually works. It takes, and the parathyroid will be working and functional. So on to the next feature, which are the pancreatic neuroendocrine tumors. They have a penetrance of 80 to 100%. There's a very wide range in the symptomatic category, but 20 to 70% can be symptomatic. And it's very difficult to distinguish benign from malignant tumors. Unlike other tumors where there are very specific criteria, in pancreatic neuroendocrine tumors, it's very difficult to determine histologically what is a benign versus a malignant tumor. So there are some criteria that have been devised to try and determine the likelihood of malignancy based on the size, if it's more than 2 centimeters in diameter, if it invades adjacent tissues, if it's necrotic, if there's atypia in the cells, if there's more than 10 mitoses per high power field, or if it's increased proliferation. And the WHO has come up with their own criteria. I don't want you to memorize this, but I just want you to be aware that there are these 3 categories that define pancreatic neuroendocrine tumors, which are well-differentiated endocrine tumors, well-differentiated endocrine carcinoma, or poorly differentiated endocrine carcinoma. That's kind of how it's staged. So what we're going to do is we're going to go through a number of cases to help you guys understand how these patients present, because I always feel clinical presentations help information stick better. So we have a case of a 30-year-old woman who had history of recurrent syncopal episodes since the age of 25. Her previous workup ruled out any cardiac or neurologic conditions as possible etiologies for her syncope. She says that she was dizzy, anxious, sweaty, and shaky, and then she passes out. And these episodes tend to happen in the middle of the night or early in the morning when she spends more than 3 hours without eating or after exercising. And she says now she finds herself eating every 2 to 3 hours to try and avoid this from happening, to prevent this from happening. And as a consequence, she's gained about 20 pounds in the last 5 years that she can't lose. So on physical exam, there's really nothing except she's found to be overweight with a BMI of 28. And then in terms of her workup, her primary care physician says, here, take a glucometer and document your blood sugars when you notice that these episodes are about to occur. And he says, don't drive until I make this diagnosis. So she comes back 2 weeks later, and she's got all these readings in the low range. 50 to 60 is the low hypoglycemic range. And the physician tells her, okay, come to my office, sit down next to me. I'm going to have you fast. I want to see what happens to you and measure some blood tests. So he sits her down in the office, and he says, every hour we're going to check your blood sugar and see how it drops, or if you become symptomatic, let me know. 3 hours later, her finger stick is 45, and he sends her blood to measure her glucose level, her proinsulin, her insulin and C-peptide. He measures her cortisol to make sure that she doesn't have adrenal insufficiency as a cause, a sulfonylurea level, which is one of the oral agents used to treat diabetes, to make sure she's not taking it surreptitiously. And he makes a biochemical diagnosis of an insulinoma. He gets an MRI, which reveals a 1.5 centimeter mass in the head of her pancreas. So insulinoma is a tumor of the pancreatic beta cells. Overall, it's the most common pancreatic neuroendocrine tumor, or sporadically. 10% of them are associated with MEN1. Typically, they're benign, although 10% can be malignant. And they classically present with what we call Whipple's triad, which is hypoglycemic symptoms. So they get these sympathetic symptoms of palpitations, diaphoresis, and tremulousness, as well as neuroglycopenic symptoms, so visual changes, confusion, abnormal behavior. And at the time of the symptoms, you have to have a documented low blood glucose level and improvement of the symptoms when the hypoglycemia is treated. And that is Whipple's triad and kind of makes the diagnosis. So the diagnostic evaluation involves evaluating for other causes of hypoglycemia, meaning using sulfonylurea or insulin use. Maybe she has a family member that takes these medications and she got a hold of it and has been taking it. And then doing the 72-hour observed fast, although recent reports are showing that 72 hours is very long, and usually the diagnosis can be made within 48 hours or even sooner. And you measure insulin, proinsulin, C-peptide, and glucose measurements during the episode of hypoglycemia. And an elevated serum insulin level more than 3 with the plasma glucose less than 55 is basically diagnostic. Then the hard part comes to localize the tumor. We use CT, MRI, endoscopic ultrasound, but often these tumors are very small and can be difficult to detect with conventional imaging. And we have a modality called selective arterial calcium stimulation, which I'll show you in a minute, which can help localize the tumor. Treatment is surgical, remove the actual tumor, but before the surgery, to prevent the symptoms, you can use a medication called diazoxide, which blocks the KATP channels that release insulin, thereby decreasing the insulin release. So intraarterial calcium stimulation is a modality that really is only used in very professional centers, such as the NIH. And it's basically using our knowledge of anatomy, yes, back to those days, where we basically know the blood supply of the pancreas, which is mainly supplied by 3 main arteries: the gastroduodenal artery, the superior mesenteric artery, and then the splenic artery. And what they do is they inject calcium into those specific arteries. Now, normally, injecting calcium shouldn't really do anything. The pathophysiology of why injecting calcium in insulinomas has not really been clearly defined, but for some reason, the calcium stimulates release of insulin from the tumor cells. So what they can do is catheterize each of the arteries supplying the pancreas, inject calcium, and look for a surge or release of insulin in the hepatic vein, in the outflow. So on the left, you see basically a very large rise in the plasma insulin level in the proximal splenic artery, indicating that the tumor is most likely located somewhere in the body of the pancreas. So on to the next case. So this is a 33-year-old woman who presents for heartburn. She's a highly successful, accomplished female. She has a 2-year history of heartburn requiring chronic treatment with proton pump inhibitors and H2 blockers. She's had 3 peptic ulcers diagnosed by endoscopy in the past, none of which were positive for H. pylori, which is an organism that can predispose to peptic ulcer disease. She's got associated symptoms of abdominal pain, diarrhea, nausea, vomiting, and she's been losing weight over the last 2 years. On physical exam, she's got a little bit of epigastric tenderness, but no rebound guarding, no palpable masses. So her primary care physician believes that despite her type A personality, these symptoms are real and she really deserves further workup. So he stops her proton pump inhibitor and he measures a serum fasting gastrin, and that is increased tenfold with a concomitant low gastric pH. And he gets an MRI, which confirms a gastrinoma in the duodenum. So gastrinomas are the most frequent functional pancreatic neuroendocrine tumors found in MEN1. 70% of them occur in the duodenum, and they tend to be multiple tumors, as you see here, multiple different foci. And up to 90% of them are malignant, and they can metastasize to the liver. Clinically, the presentation is called Zollinger-Ellison syndrome, where they present with these peptic ulcers, chronic diarrhea, abdominal pain, nausea, vomiting, and weight loss. The pathophysiology is related to high fasting serum gastrin. So normally when you eat, the gastrin levels go up, but fasting, you shouldn't really have these elevated gastrin levels, and that stimulates hypersecretion of gastric acid and results in refractory peptic ulcer disease. And these patients are at high risk of developing esophageal dysplasia. The diagnosis is made by obtaining a fasting serum gastrin level with a pH of less than 5 and obtaining gastrin level that's more than 1,000. You can also use the secretin stimulation test to stimulate gastrin release in the gastrinoma cells. Typically, secretin doesn't stimulate the normal G cells in producing gastrin, but it does in gastrinomas. And you can also do localization studies to localize the tumor, including CT, MRI, endoscopic ultrasound, or ectreotide scan. The treatment is mostly surgical, although these tumors tend to already have metastasized and be multifocal at the time of diagnosis. So they tend to require medical therapy as well, which are the high-dose proton pump inhibitors and H2 receptor antagonists. This is a tumor that you will probably never see in your career. It's very rare, but I just want to make you aware. There are fewer than 200 cases reported worldwide. It's a very slow-growing, highly malignant tumor called the glucogonoma that metastasizes to the liver. Very few, 1 to 20% of cases are associated with MEN1. And the clinical presentation is the 4Ds, where they tend to present with this necrolytic migratory erythematous dermatitis, which you see here in the pictures. They tend to have mild diabetes mellitus, deep venous thrombosis, or DVTs, and depression. They also present with GI symptoms and weight loss. And this is due to a tumor arising from the alpha cells of the pancreas that secrete glucagon. And these patients tend to have elevated plasma glucagon levels, although they can also secrete other pancreatic hormones concomitantly, such as gastrin and BIP. It's localized using CT, MRI, endoscopic ultrasound, or ectreotide scan. And the treatment involves surgical resection or medical therapy. So in no means do I want you to memorize this, but I thought that it would be helpful to kind of put together just a table of the different pancreatic tumors and their clinical presentations, where they tend to be localized, and their incidence of malignancy and associated with MEN1 that you can look at later. The last feature of MEN1, or the last most common feature, is pituitary adenomas, which you learned about a little bit earlier in the course. They tend to occur approximately in 40% of patients with MEN1. They tend to be benign tumors. They tend to be macroadenomas and more aggressive than sporadic cases. And patients tend to present with galactorrhea, visual changes. If you remember, they get the peripheral vision loss, the bitemporal hemianopsia, menstrual irregularities in women, or sexual dysfunction in men. They can co-secrete other hormones together with them, or basically just secrete either growth hormone and present as acromegaly, ACTH and present as Cushing disease, or be non-functional. The diagnosis is based on the clinical symptoms, measuring the pituitary hormones, and obtaining a pituitary MRI. Treatment involves dopamine agonists, which you guys learned about earlier, if it's a prolactinoma, or neurosurgical evaluation for the other subtypes. Screening. So who do we screen for MEN1? So we tend to screen the index case, the person presenting with the clinical symptoms of MEN1, not so much for the patient themselves, but to use that information for their family members and know that we should be more closely monitoring family members. We do screen unaffected family members of MEN1 index cases. We should have a high suspicion in patients with Zollinger-Ellison syndrome, since it's very rare outside of MEN, and patients with four-gland hyperplasia. But we don't use the screening for any therapeutic intervention. Even though we know these patients are more likely to develop tumors, parathyroid, pancreatic, or pituitary tumors, we don't go and just start removing glands preemptively, which you'll see is a little bit different than in MEN2. But we will biochemically monitor these patients annually with calcium, PTH, prolactin, IGF-1, gastrin levels, glucose, insulin, proinsulin, glucagon, and CGA to try and early detect the tumors. And we can also perform tumor imaging, meaning MRI brain or CT or MRI of the abdomen, to look for the other features every 3 to 5 years. So now we're going to move on to MEN2, which is basically broken down into 3 categories: familial medullary thyroid carcinoma, MEN2A, and MEN2B. So MEN2 as an entity is an autosomal dominant syndrome. It's a little bit more rare than MEN1. Its prevalence is 1 in 35,000, and its penetrance is 95 to 100%. And the common feature between all 3 of the subtypes is medullary thyroid cancer that occurs in up to about 100% of the patients. The diagnosis of familial medullary thyroid cancer is really detecting a familial case of medullary thyroid cancer in the absence of any of the other features associated with MEN2A or 2B. MEN2A is associated with medullary thyroid cancer. 50% will develop pheochromocytoma, which is also common in MEN2B. And the third feature is hyperparathyroidism, which occurs in 25%. MEN2B is associated with medullary thyroid cancer and pheochromocytoma, similar to MEN2A, but they also have a third feature that's different, that is they present with mucosal neuromas, ganglioneuromas, and marfanoid habitus, which I'll also show you some pictures of a little bit later. So the pathogenesis of MEN2, or familial medullary thyroid cancer, is it's caused by a germline mutation in the RET proto-oncogene. That's mapped to chromosome 10. It consists of 21 exons. And the RET protein is a member of the tyrosine kinase receptor family. It consists of 3 domains. It's got this extracellular domain, which is the cysteine-rich domain. It's got this transmembrane domain. And then it's got this intracellular tyrosine kinase catalytic domain. The MEN2A codon mutations tend to occur in the cysteine-rich domain, whereas the MEN2B most commonly exist in the tyrosine kinase domain. And familial medullary thyroid cancer can occur really across the board in the codons that are not associated with MEN2B down here and MEN2A up here. The most common mutation in MEN2A is the CYS634, which occurs, it's somewhere between 50 and 85% of patients with MEN2A. And what is different about this than in MEN1, first of all, this is a gain-of-function mutation, so you only require one allele to be mutated. But also, there is a correlation between the genotype and the phenotype, meaning the mutation or the codon mutation can be used to determine the clinical features or the aggressiveness of the tumors. And I'm going to show you a little bit more about that in a few minutes. So medullary thyroid carcinoma is the most common manifestation of MEN2. You see here you have the normal thyroid, and here you have medullary carcinoma, which is occurring in the parafollicular or C cells. It comprises about 5% of thyroid malignancies. 25% of medullary thyroid carcinoma is genetic. And of the genetic causes, these percentages have actually been changing over time. It used to be thought that 80% of cases were it actually is 80% of cases are related to MEN2A, whereas 15% are related to familial medullary carcinoma of the thyroid. It used to be thought that most of these cases were related to familial medullary carcinoma of the thyroid, but now we're finding that as we follow these patients out longer, we're picking up more cases of pheochromocytoma later on, and then they kind of fall into the category of MEN2A. So MEN2A is actually the most common, whereas familial medullary carcinoma of the thyroid is next, and then MEN2B being the most rare. So medullary carcinoma of the thyroid, like I mentioned, is a tumor of the parafollicular C cells of the thyroid, which secrete calcitonin, which is the hormone made by the C cells. It's preceded by C cell hyperplasia. And the tumor is usually unilateral in sporadic cases, can be multicentric, meaning multiple tumors occurring in familial cases. And they can metastasize to the central, lateral, cervical, mediastinal lymph nodes, or even distantly in the lung, liver, and bone. And they produce calcitonin, which serves as a tumor marker, as well as CEA, which is another tumor marker that we can follow. The diagnosis is either made by a fine needle aspiration biopsy of the thyroid nodule, along with elevated calcitonin levels. We used to use stimulated pentagastrin or calcium gluconate infusions to detect these or stimulate this calcitonin level. But now that we're doing a lot more genetic diagnosis, it's not really needed as much if you know that the patient already has a diagnosis of MEN2. Okay. So when I mentioned before that there is a correlation between the genotype and phenotype, this is actually being used in the management of patients. And we use the specific mutated codon in the RET gene to correlate with the MEN2 variant and the aggressiveness of the medullary thyroid cancer. And we plan surgery, meaning the thyroidectomy, according to the known RET mutation. There are a bunch of different groups that have come out with different levels and different codons and when thyroidectomy should occur. I put one up here in the review article that's online. You'll see there are 5 different associations, and they each have a little bit of a different algorithm. But the point is, the more aggressive tumors, meaning the MEN2B or RET codon 883, 918, 922, which are down here in the tyrosine kinase domain, those tend to be more aggressive. They present earlier, and therefore we do thyroidectomy before the age of 6 months in babies that are known to be carriers. Level 2 mutations, which are up here, usually associated with MEN2A or familial medullary thyroid cancer, are in this intermediate level, and we perform thyroidectomy before the age of 5 years. Whereas the level 1 mutations are a little less aggressive, and we can delay thyroidectomy to about somewhere between 5 and 10 years of age. So treatment of medullary thyroid cancer, like I mentioned, is a total thyroidectomy, plus we will also do a central node dissection in patients that are not having their thyroidectomy in the case of MEN2A before the age of 5. If we're doing thyroidectomies later on, they have to have the central nodes dissected. And in all of MEN2B cases, they get central node dissection. What's important is to screen patients with MEN2 for pheochromocytomas before sending them for thyroidectomy, because if there's a pheochromocytoma that goes undiagnosed and the patient goes for surgery, they are at risk for having a surge of malignant hypertension, which we'll go through the pheochromocytoma in a few minutes, but that can basically be fatal. So they should be screened for pheochromocytoma before undergoing thyroidectomy. Postoperatively, we follow their calcitonin and CEA levels. Chemo and radiation are not effective treatments for this disease. And there are phase 3 trials that have demonstrated prolongation of progression-free survival using tyrosine kinase inhibitors. So that can be used in some refractory cases. So now we're going to move on to the next feature of MEN2 with a case. So chief complaint is palpitations, headache, and difficult to control hypertension. We have a 55-year-old male who's got long-standing severe hypertension, which is difficult to control despite being on 4 different antihypertensives. He reports symptoms that have been progressively worsening, spells of palpitations, pallor, headache, diaphoresis, and he also describes that he's been extremely anxious lately, and he's got these paroxysms of pain in his abdomen. On physical exam, he's got marked hypertension with a blood pressure of 170/110. He's got a fast heart rate, sinus tachycardia. He's got mild right upper quadrant tenderness, no rebound guarding, palpable masses, or abdominal bruits. So after reviewing the patient's medication, his primary care doctor is concerned that his presenting symptoms and uncontrolled hypertension are pretty extreme, and he says, okay, this is probably not our run-of-the-mill benign essential hypertension. Let's work him up for another cause. So he sends the following tests. He measures TSH free T4 to rule out hyperthyroidism. He sends aldosterone and plasma renin activity to rule out primary hyperaldosteronism. And then he collects a 24-hour urine collection for metanephrines and catecholamines. So his lab tests come back with elevated metanephrines and catecholamines, and the PMD sends him for imaging of his belly. So this guy's got a pheochromocytoma, and as you see here, the red arrow is the tumor, which in this case is large. It doesn't have to be that large, whereas the white arrow is the normal adrenal gland. This is the image of the gross pathology of the pheochromocytoma. It tends to have a lot of necrotic areas, and on histology you see here these are the chromaffin cells that are involved in the pheochromocytoma. So as you have learned before, the adrenal gland contains an adrenal cortex and a medulla. The cortex consists of the zona glomerulosa, the zona fasciculata, and the zona reticularis that secrete aldosterone, cortisol, and androgens. And then we have in the middle the medulla, which is responsible for secreting the catecholamines. And I don't want you to memorize this in any way. This is the catecholamine biosynthesis and metabolism pathway. And the catecholamines tend to originate from tyrosine, and they eventually get converted down the line to DOPA, dopamine, norepinephrine, and epinephrine. And then further, they get metabolized to metanephrines and normetanephrines. What I want you to know is that the norepinephrine gets converted to epinephrine by this enzyme PNMT. PNMT lives in the adrenal medulla and is stimulated by cortisol. So in patients with pheochromocytoma occurring in the adrenal gland, you can also get, which I didn't mention, something called paragangliomas, which are basically pheochromocytomas occurring outside the adrenal gland. But pheochromocytomas occurring in the adrenal gland, so they're part of the adrenal medulla. This enzyme, PNMT, is kind of being bathed by cortisol being released from the adrenal cortex. And this cortisol stimulates the conversion of norepinephrine to epinephrine. So in pheochromocytomas, you see an elevated epinephrine to norepinephrine ratio relative to paragangliomas, which don't have this PNMT enzyme because they're located outside the adrenal gland, and they primarily secrete norepinephrine. So pheochromocytomas are tumors that arise from the chromaffin cells of the adrenal medulla. They synthesize, store, metabolize, and secrete catecholamines, and they can develop in about 50% of individuals with MEN2, both A and B, and often it's preceded by the diagnosis of medullary carcinoma of the thyroid. It's got a rule of 10s. 10% are bilateral, 10% are malignant, and 10% occur extra-adrenal. There used to be a rule of 10 for genetic causes, but that actually has gone up to almost 25% in recent years. So clinically, they tend to present with this classic triad where they have episodic headaches, sweating, palpitations, they have hypertension, which is a very remarkable symptom, syncope, pallor, panic attacks, and abdominal pain. And the abdominal pain is due to the necrosis of the tumor in the abdomen. And they have elevated plasma metanephrines, which is a very highly sensitive test. And they also have elevated chromogranin A, which is one of the granule markers that tends to be highly associated with pheochromocytoma. They have elevated 24-hour urine metanephrines that it's also very highly specific, and catecholamines are elevated. And usually the imaging we do are adrenal CAT scan or MRI or nuclear medicine MIBG scan. Treatment is surgery, but before we go for surgery, we need to medically treat them to prevent malignant hypertension from occurring in the operating room. So we give them first alpha blockers, followed by beta blockers or calcium channel blockers to control the hypertension. So MEN2, just to review, 2A, medullary thyroid cancer, pheochromocytoma, and hyperparathyroidism, 2B, medullary thyroid cancer, pheochromocytoma, and then the mucosal neuromas, ganglioneuromas, and marfanoid habitus. So MEN2B, these are some of the features of that last category, the marfanoid habitus, where you see this gentleman has a very large arm span. He's tall, but he's got very wide arms, and he's got these mucosal neuromas in the back of his tongue. And this is classically how they appear. So screening. So at-risk patients for MEN2A, 2B, and familial medullary thyroid cancer should undergo genetic testing to identify mutations in the RET gene. And all patients with medullary thyroid cancer should be screened because of the high incidence of tumors that appear to be sporadic that are actually harboring RET mutations. So if positive for familial medullary thyroid cancer, we do total thyroidectomy. For MEN2A, they get total thyroidectomy, and then we follow them annually to look for pheochromocytoma with plasma or urine metanephrines or catecholamines, and we get annual calcium and PTH to look for hyperparathyroidism. If they're positive for MEN2B, they get the total thyroidectomy as well as annual plasma, urine metanephrines, and catecholamines to look for pheochromocytoma. So in summary, MEN1 versus MEN2. MEN1 consists of the 3 Ps: hyperparathyroidism, pancreatic tumors, pituitary tumors, whereas MEN2 is medullary carcinoma of the thyroid along with pheochromocytoma, and in A they develop hyperparathyroidism, whereas in B they develop neuromas. The MEN1 gene is responsible for the MEN1 syndrome. It's a tumor suppressor gene, and MEN1 encodes the menin protein. MEN2 is the RET proto-oncogene. It's a gain-of-function mutation and involves the tyrosine kinase receptor. MEN1, there's no clear phenotype and genotype relation, so we don't really change our management based on knowing this, aside for really close monitoring of the patients for development of the tumors, whereas MEN2, there's a clear genotype-phenotype relationship, and we actually use it to guide our management and how early to perform thyroidectomy in these patients. For MEN1, we screen with genetic testing and annual surveillance, whereas in MEN2, they are genetically tested. They undergo total thyroidectomy, and then they're surveyed annually for the other features. That's it. Finished a little early, so any questions, I'm happy to hang around and answer if anybody wants to come up. Thank you.